Everybody, I hope that you can hear me. So may I have the first slide, please? I would like to turn on your attention onto problematic of lipoprotein little a. So still waiting for the first slide. Okay, thank you. Well, so the next slide, please. As we heard, we focus when we discuss the problem of atherosclerosis on mainly LDL cholesterol. However, there are also several other particles which are very important for carrying a lot of cholesterol burden in the human body. And lipoprotein little a is one of them. As you can mention, the amount of cholesterol which is carrying in that molecule is almost the same as an LDL particle. Next slide, please. And then concerning the lipid risk factors for cardiovascular diseases, increased LDL, decreased HDL, and increased triglycerides. Next one, please. It's obvious, and we count that as a modifiable risk factors. We do have some pharmacotherapy for that particular particles. The next slide, please. However, for increased lipoprotein little a, there are still some question markers concerning mainly the approach and the therapy for that. The next one, please. However, we do have a lot of evidence that suggests that elevated lipoprotein little a is associated with a future and accelerated progression of mainly high-risk plaques in the future. As you can see here, there's an example of a patient with increased lipoprotein little a levels, and you can see on the first picture that after 1 year follow-up is the next one to the right, you can see a lot of progression in his atherosclerosis concerning coronary vessels because of elevated LP little a levels. And we count that as independent of traditional cardiovascular risk factors. The next one, please. The next slide, please. And a back one, please. Well, the question is how important is that question, whether there are many or not as many of patients with increased LP little a. And these days we know that approximately 20%, it means 1 in 5 individuals can have genetically determined elevated lipoprotein little a levels. Some of them less, some of them more, but mainly 20% of population can have this disadvantage. And that increased LP little a influences heterogeneity from the very birth. It's genetically determined. Next, please. And so what do we do know about influence on lipoprotein little a? The strongest influence comes from birth. We know that it's a co-dominant inheritance, and genetic accounts for approximately up to 90% of the LP little a levels. Then we have some differences based on ethnicum. We can see increase in renal dysfunction or decreased with liver dysfunction. And what is of small or without any influence is age, then sex, and with slight increase after menopause because of estrogens, and then some hormones, diet, and exercise, and unfortunately, majority of so far available drugs can have very small influence on LP little a levels. The next slide, please. However, elevated LP little a is independent and causally associated with increased risk of cardiovascular complications like MI, peripheral atherosclerosis, and even cardiovascular mortality. As you can see on the left side, elevated LP little a levels can more than double the risk of MI with increasing the levels of Lp(a), and that increase also increases the lifetime risk of major cardiovascular events based on actual level of Lp(a). So it means that it is very important to measure Lp(a) levels because otherwise the lifetime risk of cardiovascular diseases and events would be substantially underestimated. Next slide, please. Oh, well, what do we know about the situation? How Lp(a) independently increases risk of premature or recurrent cardiovascular event? We do have a lot of information concerning that. For example, one study described in the case controls 1,500 patients with acute coronary syndrome and match controls without any cardiovascular disease, and they were younger patients. They were less than 45 years of age, and you can see that every increase in Lp(a) by 10 milligrams per deciliter increases the likelihood of acute coronary syndrome by 4%. And when we see the patients with Lp(a) more than 50 milligrams per deciliter, we do have a threefold increase in the risk of acute coronary syndrome. The next slide, please. Well, and based on that, there are some recommendations concerning that. The first one comes from 2022. It's consensus of European Atherosclerosis Society on Lp(a). Based on that, we now know that Lp(a) presents continuous association with the increased risk of cardiovascular diseases. That's a new risk factor for aortic valve stenosis. On the contrary, very low Lp(a) levels may associate with type 2 diabetes. And besides that, we know that it is not a risk factor for venous thrombosis. The next slide, please. And then in the last year, we saw an update of that previous consensus with the numbers showing that how Lp(a) is associated with lifetime risk for major cardiovascular events. And from that, we know that the cutoff values are approximately 50 milligrams per deciliter, or as you can see, also 105 nanomoles per liter. It's a borderline for increased cardiovascular risk. The next slide, please. Screening and measuring of Lp(a) is of great importance, especially in younger patients or the patients with familial hypercholesterolemia or patients with premature atherosclerotic cardiovascular disease. Family history is very important. We look mainly for premature cardiovascular disease and occurrence of that, or high Lp(a) in the parents or brothers, sisters, etc. Well, we know that Lp(a) is predominantly genetically determined, so measurement at least once in lifetime is very wise. We know that it may increase after menopause, so in that woman, a second measurement may be appropriate. And we also know that because of the variability between different assays of Lp(a), we prefer measurement in molar units. It means, for example, in nanomoles per liter. The next slide, please. The first information concerning Lp(a) is quite old. It's more than 60 years old, and it was first described in 1963. And then it took nearly 50 years before we demonstrated that elevated Lp(a) concentration is an independent and causal risk of atherosclerotic cardiovascular disease. Next slide, please. That is from the study from Copenhagen City Heart Study. Next one, please. where almost more than 9,000 patients were compared based on the Lp(a) status. The next slide, please. These patients were followed for 10 years, and from that we know that each increase in Lp(a) increases also the occurrence of myocardial infarction or ischemic heart disease. Next slide, please. And then all of the data were put together, became aware that that risk uh, is independent. uh, it is not associated with uh, other cardiovascular, traditional cardiovascular diseases and factors. Next slide, please. Then from that study from Copenhagen, we also know that Lp(a) adds some more risk for actual situation in individual patient. So it may increase the risk, for example, for the heart failure, peripheral arterial disease, cardiovascular mortality, all-cause mortality, abdominal aortic aneurysm, and also, for example, for chronic kidney disease. The next slide, please. The question is, why can Lp(a) increase cardiovascular risk? There are several factors that are important from that point of view. So first of all, Lp(a) is a pro-inflammatory agent. There are several data from experiments, and they demonstrate that, for example, increased Lp(a) is associated with increased expression of pro-inflammatory macrophages, etc. It's also pro-atherogenic because it affects all the basic steps of atherosclerosis, for example, endothelial cell binding, smooth muscle cell proliferation, necrotic core formation of atherosclerotic blood, for example. And it's also prothrombotic because of, for example, decreased plasminogen activation, increased platelet activation, decreased fibrin degradation. So all of that forms heterogeneity for Lp(a). The next slide, please. And what is very important for routine practice is that besides genetical determination of Lp(a), the traditional lifestyle modification does not have significant influence of Lp(a), and that's a very crucial point for these days. The next slide, please. Well, so how can you influence levels of Lp(a)? As we told that lifestyle modification, unfortunately, does not work very much. However, it is very important to keep the patient going in increased physical activity, healthy diet, which can have some small positive effect on Lp(a) concentration. And concerning lipid-lowering therapies, what do we know? Niacin. Niacin was one of the first hypolipidemic agents, which was shown to reduce Lp(a) by more than 30% in two clinical trials. However, as we know, niacin has severe adverse side effects, and it is not used quite often these days. And concerning other accessible lipid-lowering agents like CETP inhibitors, MTP inhibitors, all of that show promising Lp(a) lowering effect, but clinical trials are not more running these days. The next slide, please. So, what about other hypolipidemics? How can they influence the level of Lp(a)? When we start with statins, we can see a good decrease for LDL cholesterol. However, even slight increase in Lp(a) concentration. Niacin was already discussed, and the other molecules, the new hypolipidemics like PCSK9 monoclonal antibodies, they can decrease Lp(a) up to 24%, increase around up to 26%. and that extracorporeal apheresis, which is used also in some centers, up to 35%. The next slide, please. Well, when we put LP little a targeted therapies, they can lower that agent. It is not much to be offered these days. Besides that, as was already mentioned, like lipoprotein apheresis or some drugs which are used to treat, for example, our FH patients, and that there are some future LP targeted therapies which can come from the results are coming from running studies, and they are or injectable agents or even, for example, muvalapine oral therapy agents or some therapies which use silencing RNA like or for example. The next slide, please. And then the next one, please. Next. You see here the therapeutic approaches which are now under investigation. The next one, please. The next. The next. And then what's on the very end, however, which could be promising future is CRISPR-Cas technology with permanent LP delay decrease. However, it is not still used in the practice so far. The next slide, please. So, what's the take-home message? LP little a, because of genetical determinants, should be measured at least once per life. Then increased levels more than 105 nanomoles per liter are based on the recommendation for ES, some modifiers of cardiovascular risk. The treatment for these days concerning LP little a apheresis can reduce that by 35%. And we are looking for innovative therapies like antisense oligonucleotides, silencing of RNA and small molecules in the running clinical trials. But before that therapy will come to target, we should use targeted therapy, which is necessary to intervene modifiable risk factors, which can do these days. So thank you for your attention.